Do we have more research we could do? Absolutely. But this connection between housing as a structural intervention and positive health outcomes, that's been proven now. We've demonstrated it now. There's not an argument in my mind and many others that are here that we clearly have the evidence. What we now need is the investment. So we have the evidence. Now let's invest in the right interventions because we know they work and they're going to be effective. So let's do that.
Supportive housing would be great. We just had a presentation by Suzanne Wenzel that was talking about supportive housing in LA. And it was fantastic. And we've seen some of that in San Francisco of the supportive housing studies and of the reports that we've seen. It works. And it's too bad there's not more of it, because it's not just the housing, but it's also the mental health treatment. It's the addiction treatment. It's having all types of support so that people can stay on treatment, be more consistent, feel that support, and get on a road to having a better life and getting out of some of the bad situations that they were in.
In New York, we're creating metrics around housing stability, around employment, around food security, so that we're not just measuring people's viral load and whether or not they're virally suppressed, but can they actually live their lives well? The fact of the matter is, and I said this this morning, I don't even use the language of treatment as prevention, because the number one reason I want you to go on treatment is for your own well-being. And it's a collateral effect, a side effect, that by doing that, you also ensure that you can't transmit the virus to anyone else. That doesn't mean that, we certainly celebrate at Housing Works viral suppression as contributing to ending the epidemic. That's what this button represents. It's somebody who's undetectable. We like to tell folk who come to Housing Works for their care that you're a superhero by staying completely virally suppressed, because what you're doing is you're guaranteeing that the epidemic ends with you.
And it was a multi-tiered toolkit. The first level, which is not on there actually, is the concept social marketing design, whereby a comic was created with a graphic artist that motivated folks to buy into this undetectable project, right? And that was supposed to motivate both clients as well as folks who are case managers. Another very, very important part of the toolkit was to link case managers up with a team of primary care providers, health providers, and make viral load suppression as a central objective of that team. And folks met regularly case conferencing clients around it. Another extremely important part, and this is the one that gets a lot of play, is the contingency management or the incentives part of the project, where folks who were enrolled in the project were given a $100 gift card at their quarterly lab testing results if they were undetectable. So that served as a monetary incentive. They came in, they could get 4 per year. So that was a significant portion of money for folks, obviously, in this community. It also has been shown to be the kind of optimal incentive in the literature that is effective.
So I know this is easier said than done, but now that King has been decided and the ACA seems like it's here to stay, knock on wood, this is a good chance to go back to your state if you live in a state without Medicaid expansion and to start putting pressure on regulators, on legislatures, go back to insurers and say, hey, this is in your interest, because then you might be able to offer a Medicaid managed care plan. Let's advocate to expand Medicaid in our state, even if it has to be done through a premium assistance program in which the state will buy plans, specially designed plans for people as opposed to get them into Medicaid. The next recommendation revolves around preventive services. So the ACA is trying to move our healthcare system to a more preventive model, which is great. Right now, all private insurers, Medicare and Medicaid, but expansion Medicaid, must provide free preventive services. And this is particularly good for the low-income population because beforehand, under EMTALA, they knew that the emergency rooms had to treat them so they could go there and they could get the services and maybe figure it out later. But they didn't really have a good way to access preventive services. And those are the services we'd like to see them get. We'd like to see them have interventions before they get stuck in the ED. Unfortunately, states only have the option of providing free preventive services to traditional Medicaid beneficiaries. They don't have to. They only get a 1% increase in the federal matching rate, which hasn't been enough of an incentive. So there needs to be pressure on states to expand preventive services to their lower income people in traditional Medicaid. The last recommendation I'm going to give is health homes, and that's not housing in the traditional sense, but it houses people medically. And the ACA opened the option for states to establish these health homes for chronic diseases. Originally, HIV wasn't on the list of chronic diseases, but through advocacy, they were added. So states can create health homes centered around HIV. The states that have done it have seen success. New York State, most prominently, was the first to do it and move all of their people into a managed care health home structure. And so again, these are 3 opportunities that aren't being taken care of, that aren't being taken advantage of consistently across the country and could really benefit people living from HIV because, as we've seen, HIV is exactly the kind of chronic, serious condition that when managed well and managed carefully can be something people can live with for years and reach viral suppression and have really different outcomes than when they're receiving spotty care because their insurance isn't sufficient or they're uninsured. So I strongly urge all of you guys to go back and not only think about your day-to-day, I'm sure you've got a lot piling up by being here, but also think about, well, how can I convince my state and my community to really take advantage of the opportunities in the ACA?
So moving research evidence into action, it's incredible how much research we generate. And I think what we're doing is trying to take a conscious look at that evidence, from single studies to bodies of work to systematic reviews in very rigorous ways to understand, what is the evidence telling us and how we can act on it. And so we spend a lot of time, we have teams at the OHTN and others that we're involved with spend considerable amount of time really making sure that we're not duplicating efforts or how we can learn from studies that are happening in different places, in different contexts, and take that work and then apply it or look how we can adapt and apply it in our local communities, in our regions. And so there's a lot of work sort of really wanting to synthesize that, but then apply it. And I think our approach to interventions is to make sure that we're really have the latest evidence. And then the next piece is to then think about a lot of the work that we're doing is working with people and priority populations in their communities, in their social contexts. And so our next step is to think about not just what the findings told us, but then how we can then build those into approaches, interventions, and programs to really help people to look at how we can change the negative things that happen to people through this intervention work.
Space matters. When you're in the same space and you're hearing the same challenges that we face, but also the successes, you get energized. And it re-energizes you and ignites your passion to why we do the work that we do. We don't always get that time. And we're all in our own communities and we're all working, doing great work, but to be able to come together and say, we can do this together, and that we're on the edge of actually seeing the difference our efforts are making, that's exciting. And we don't get that opportunity. And I think those are the reasons why it's important to be together like this.
I think that international engagement is key. And I'll say that, like in my thinking around homelessness, the aha moments, the paradigm shifting moments have generally come from international engagement. So either in the United States or Australia, they're miles ahead of us on youth homelessness, or in Europe. It's when you go somewhere else, it's actually helpful because people do things differently, and we often use the fact that the policy context is different to suggest that we shouldn't look at other things, right? It's like, well, it's different in Europe. They have a more robust welfare state. And it's like, no. Look at what they're doing and figure out how we can adapt it. And there's so much, the difference between Canada and the U.S. is there in some ways in terms of how we structure government and services and healthcare and those kinds of things. But there's lots of similarities, and when we work collaboratively, like that's where the magic happens.